Congenital short QT syndrome is an extremely rare, highly lethal inherited channelopathy first identified in 2000. It is characterized by an abnormally abbreviated repolarization phase which significantly increases susceptibility to atrial and ventricular arrhythmias, syncope, and sudden cardiac death in patients with structurally normal hearts. To date, fewer than 350 cases have been reported worldwide in the literature, though the condition is likely underdiagnosed. The diagnosis of short QT syndrome relies heavily on the 12-lead ECG, though defining the absolute cutoff for a short QTC has been historically controversial since the lower limits of normal overlap with disease state. Current guidelines generally diagnose SQTS based on the following: definite SQTS, a corrected QTC 340 milliseconds or lower on resting ECG. Probable SQTS, a QTC 360 milliseconds or lower combined with one or more clinical factors: a confirmed pathogenic mutation, a family history of SQTS, a family history of SCD before age 40, or a personal history of cardiac arrest or unexplained syncope. The QT interval should be ideally measured at heart rates near 60 beats per minute, as SQTS patients exhibit a characteristic lack of QT adaptation to heart rate changes. The QT interval remains relatively fixed even at slower rates. Key morphological features on the ECG: absent or virtually absent ST segment. The T wave begins immediately following the QRS complex. T wave morphology. The T waves are typically tall, peaked, symmetrical, and narrow based, particularly in the precordial leads. Depression of the PQ segment, often observed due to a heterogeneous abbreviation of atrial repolarization. SQTS is primarily inherited as an autosomal dominant pattern. The syndrome is driven by a fundamental imbalance during the plateau and repolarization phases of the cardiac action potential. The outward potassium currents overpower the inward calcium currents. This abbreviated repolarization shortens the effective refractory period, creating a vulnerable window where premature atrial or ventricular stimuli can easily trigger re-entrant arrhythmias like atrial fibrillation or ventricular fibrillation. While 9 genes have been loosely associated with the syndrome, only a few are considered definitely causal. Gain of function mutations in potassium channels KCNH2 SQT1 affects IKR. KCNQ1 SQT2 affects IKS. KCNJ2 SQT3 affects IK1. Loss of function mutations in calcium channels, less common, often presenting with Brugada-like overlap phenotype, CACNA1C, CACNA2D1, CACNB2. Despite advances in genetic screening, the diagnostic yield remains low, under 30 to 40%, meaning the majority of clinically diagnosed SQTS patients do not have an identified genetic mutation. The clinical penetrance and expressivity of SQTS are highly variable. Some patients remain entirely asymptomatic while others suffer lethal arrhythmias. Sudden cardiac death. This can be the first manifestation in up to 40% cases. There are two distinct high-risk peaks for SCD. The first year of life, making SQTS a notable cause for sudden infant death syndrome or SIDS, and between 20 to 40 years. Atrial fibrillation, AFib, is extremely common and is often the first symptom, particularly notable when it presents in young, otherwise healthy individuals or neonates. Other symptoms: unexplained syncope, dizziness and palpitation are frequent, often triggered by adrenergic states, noise, exercise. though events can also occur at rest. Because of high lethality and young age of onset, management is aggressive but presents unique clinical challenges. Implantable cardioverter defibrillator. This is the first line definitive therapy for secondary prevention, that is, patients who have survived a cardiac arrest or sustained VTVF, and often for primary prevention in high-risk patients. However, ICD placement in SQTS is notoriously difficult. The tall peaked T waves characteristic of the syndrome frequently lead to T wave oversensing, resulting in inappropriate and painful shocks. This requires meticulous device programming and specialized lead placement. Pharmacotherapy. Quinidine, often administered as hydroquinidine, is the pharmacological treatment of choice. By blocking multiple potassium channels, primarily IKR, ITO, and IK1, it effectively prolongs the QT interval and increases the refractory period, restoring a more normal action potential and significantly reducing the inducibility of ventricular arrhythmias. It is heavily utilized as an adjunct to ICD therapy to prevent frequent shocks or as primary therapy in pediatric patients where ICD implantation is technically contraindicated. Research into congenital short QT syndromes remains challenging due to the extreme rarity of the condition. However, several studies published between 2024 and 2026 have made significant strides in risk stratification, genetic profiling, and diagnostic testing. Here are the most notable recent advancements in the field. Refining risk stratification, the less than or equal to 320 millisecond threshold. Historically, proving that a shorter QT interval correlates with a higher risk of sudden cardiac death in SQTS has been difficult. A major 2026 pooled analysis published in Heart Rhythm evaluated 162 patients with SQTS to address this gap. The study definitively demonstrated an inverse relationship between QTC duration and arrhythmic symptoms. High risk cutoff. The researchers found that a QTC of 320 milliseconds or lower strongly correlates with a higher risk of malignant ventricular arrhythmias and cardiac arrest. Demographic risk. The cohort also revealed that male patients are overrepresented in the SQTS population and face a statistically higher risk of malignant symptoms compared to females. Novel genetic drivers, the SCLC4A3 gene. While potassium and calcium channel mutations like KCNH2, KCNQ1, CASCNA1C are the classic culprits, a 2025 study in JACC Clinical Electrophysiology expanded the genetic landscape by identifying a novel gain-of-function mutation in the SLC4A3 gene, specifically PR1016G variant. The SLC-A3 soluble carrier family 4 member 3 gene encodes the anion exchanger 3 protein, which regulates intracellular pH and chloride levels. Previously, only loss of function variants in this gene were thought to be associated with SQTS. This discovery highlights that the molecular mechanisms driving the syndrome are more diverse than originally understood, and recent case reports suggest that repolarization abnormalities and T-wave morphology may be highly genotype dependent. One of the primary diagnostic hurdles in short QT syndrome is the overlap in resting QTC values between healthy individuals and affected patients. Furthermore, SQTS patients classically fail to prolong their QT interval during bradycardia. Study published in JACC Clinical Electrophysiology in 2025 introduced a novel provocation maneuver termed the IPON test. The test induces a sudden heart rate deceleration. It combines Valsalva technique with a sudden postural change to induce a rapid deceleration of the heart rate. The name was given because it is reminiscent of an Ippon maneuver during judo competition. While patient was performing forced expiration through an empty 10 ml syringe for 15 seconds, resting in a propped up position, bed was rapidly lowered to horizontal flat position. Simultaneously, legs of the patient were passively elevated by a staff member to 45 degrees for 15 seconds to achieve maximal bradycardia as the patient resumed quite normal breathing. In healthy individuals, the QT interval naturally prolongs as the heart rate slows. In those with short QT syndrome variants, the QT interval fails to adapt, remaining inappropriately short. The researchers noted that this dynamic provocation maneuver identified short QT syndrome with significantly higher diagnostic accuracy than resting Holter monitors alone. A 2025 scoping review in the Journal of Personalized Medicine evaluated the current clinical management of the syndrome. While implantable cardioverter defibrillators remain the gold standard for secondary prevention, the review highlighted a growing reliance on targeted pharmacotherapy, primarily hydroquinone, for primary prevention. Because inappropriate ICD shocks due to T-wave oversensing remain a massive burden, especially in the pediatric population, hydroquinone is increasingly being utilized either to bridge young patients until an ICD is anatomically feasible or as a standalone therapy in asymptomatic patients with a high-risk family history.